Pain in the back could be due to injury, infection, tumor, or disc problems. A definitive diagnosis should be made as early as possible because only when you make a diagnosis and treat it properly, pain in the back should not be ignored even if it is a very short duration. I will give you an example. This young boy of 18 years developed pain in the back lasting for a few weeks. But the important point is the pain was gradually worsening and becoming bad and bad that he was confined to bed in a few weeks. I will now show you the X-ray. These are the plain X-rays of the patient focusing the lower thoracic region. You have an AP view and a lateral view. You can see that there is no radiologically demonstrable lesion both in the AP view and in the lateral view. These X-rays can be passed as essentially normal. Now I will show you the scans, the CT scans of the patient. This scan was taken, the first scan that was taken, and you can see that there is a lytic lesion on D12 vertebral body. It is so small, located anteriorly, and this is the sagittal reconstruction which shows the lesion. The other vertebral bodies are all normal. This scan was taken 3 weeks after the first scan, but this shows an increase in the amount of lytic lesion at D12. In addition, there is lesions in D11 vertebral body also. You can see that this is the coronal reconstruction showing the lesion. This patient had the treatment with antituberculous drugs from the very beginning. The lesion has worsened in spite of the antituberculous treatment. This scan was taken 1 week after the second scan. Here again you see that the lesion has crossed over the disc space and invaded the proximal vertebral body also. This is important, and because this patient's condition is worsening in spite of the treatment, we decided to operate on this patient. Here you can see that there is a lesion which is trying to encroach on the vertebral canal. You can see this is the sagittal reconstruction showing the extent of the lesion. Now we will proceed to the surgical procedure. This is the first CT scan. D11 is normal. This is the second CT scan involving the D11 and D12 vertebral bodies. This is the coronal reconstruction. Now we will go over to the surgery. We decided to operate on this patient through a left thoracotomy approach. The patient is positioned on the table on the right lateral position, and the table is angled so that the left ribs and interspaces spread out. The level of lesion is D11-12. It is better approached through a D10 thoracotomy approach. Now we can see that the 10th rib is marked. The 10th rib is marked by identifying the 11th and 12th ribs and then counting backwards. The first step is harvesting bone grafts. This is done from the anterior part of ilia crest, because what we need is only a small amount of cancellous bone. The incision is made on the anterior 1/3 of the iliac crest. The vessels are cauterized. We have slightly modified the procedure of harvesting bone grafts. Because we need only cancellous bone, the inner table is not exposed. We make an incision, elevate the periosteum, and subperiosteally expose the outer surface of the anterior third of the ilium. You can see that the iliac crest is being exposed by short dissection, and once you come to the lateral margin of the iliac split in the iliac crest so that an outer table can be removed alone without disturbing the inner table. The osteotomy goes vertically down from the iliac crest. Cuts are made on either side, anteriorly and posteriorly. Cut is made in the inferior part of the outer cortex as well, so that you can split open the outer cortex easily. Now the outer cortex is being removed again with a curved osteotome so that you don't penetrate into the inner cortex. part of the outer cortex is removed. With a curved gouge, you can harvest as much as cancellous bone as possible. Only cancellous bone, which is ideal for filling the cage which we are going to use for fusion. Remove as much cancellous bone as possible. We have a good amount of cancellous bone, and this is enough for filling the titanium cage which we are going to use for the as a spacer. Closure is done with Vicryl. I don't usually leave a drain in the wound. The wound is closed without any dead space and after perfect hemostasis. Now we are going to the thoracotomy part of the surgery. Incision is made right over the 10th rib. The incision starts from the costochondral junction and ends at the lateral border of the paraspinal muscles. Once again, make sure that you are right on the 10th rib. It will be difficult to expose the 11th and 12th vertebral bodies if you don't go right over the 10th rib. Skin incision is deepened to the subcutaneous layer. All bleeding points should be thoroughly cauterized, because if there is skin bleeding, this can interfere with the field while you are exposing the body of the vertebra. You can see that there are some muscle fibers underneath. We are not going through the subcutaneous layer. The vessels are meticulously cauterized. Now you can use electrocautery, but make sure that you are right over the rib. Palpate the rib continuously. Make sure that you are right over the rib. You are right on the surface of the rib. Now I am incising the periosteum of the 10th rib. Meticulously elevate the periosteum, first on the superior surface, superior margin, care should be taken not to injure the pleura underneath while you elevate the periosteum. Elevate the periosteum from the lower margin of the rib. You should be careful not to injure the intercostal vessels and nerves. Injury to the intercostal vessel can produce bleeding, and preserving the intercostal nerve can lead you comfortably to the dura. In addition, any damage can produce neuroma, which can be painful in the postoperative period. The rib is exposed almost fully, except some portions in the lower margin. Carefully elevate the periosteum from the inferior margin of the Now the rib is separate. Make a cut in the anterior part. And another in the posterior part of the rib. And remove the rib. Now the periosteum with the parietal pleura is exposed. You can make a small incision. Make sure that the surface is clean, there is no bleeders. Cauterize if there is any. A small incision in the parietal pleura. Taking care not to incise the lung underneath. Now there is a small opening. You can lift up the opening and expand this anteriorly and posteriorly using scissors. can use little bone bags to stop bleeding from the cut end of the rib. Complete the incision of the pleura. After bluntly separating the lungs with the finger, now the thoracic cavity is opened. Now you are right on the vertebral bodies. You see a few drops of pus coming out. I use this curette to remove the damaged vertebral bodies. You can see the heart there. We have removed the vertebral bodies D11 and D12 with the intervening disc. These are titanium cages available in various lengths and diameters. A proper size titanium cage is selected. The inside of the cage is filled with bone grafts. And the bone graft is impacted. We've got a solid block of bone in the inner side of the titanium cage. The cage is now inserted into the space created by the removal of the vertebral body. Now the cage is in situ. closure is done with Vicryl in two layers, one for the periosteum over the body of vertebra as interrupted sutures, and then the parietal pleura over the body of vertebra is sutured. Once you keep the titanium cage inside, the table is straightened so that the titanium cage gets trapped between the vertebra above and the vertebra below. It becomes a very rigid fixation. Now we proceed on to the closure. Before closure, an intercostal drain is inserted into the intercostal space above and brought out through a separate